Okay, so I'm going to look at consent in children, and I want to point people that don't know about this publication from the Children's Institute. It's a fantastic guide. It's got cases, among others, Prof McKerrow's done some cases in the book, and it's really a fantastic guide to what we should be doing. So I want to run through some scenarios. So the first scenario is 12-year-old Skylar has asthma. She has repeated exacerbations and hospital admissions, never actively involved in discussions about her treatment and inhaler choices with her healthcare provider. All the engagement is with her mother, and then they give instructions to Skylar. 3-month-old Bongi needs surgery for an inguinal hernia. His mother, 17, who should consent to his surgery. Slightly different scenario, he needs emergency surgery for intussusception. His mother, 17 years old and estranged from her family, who should consent to his surgery. 14-year-old Andisa has osteosarcoma. She's completed a course of chemotherapy and now requires amputation. And she and her mother say they cannot make a decision without consulting the elders in their family. What do you do now? And then 4-year-old Luke with a medulloblastoma with full surgical resection that's possible. Luke's mother and father never married. His mother passed away when he was 6 months old. Can the father give consent for the procedure? So the way I'd like to approach this is to look at, first of all, the ethical requirements for informed consent, talk about children in decision-making, go through the Children's Act in terms of medical and surgical treatment consent and HIV testing, and then just briefly touch on consent in other legislation. So what is informed consent? It's a consent for treatment or research given by a competent individual who's received the necessary information, has adequately understood the information, and after considering the information has arrived at a decision without having been subjected to coercion, undue influence, or intimidation. There are threshold elements that are important for morally valid consent. So the first one is disclosure. The patient must have access to all the information to be able to make a choice. The patient must be able to understand that information. The patient must feel free to make the decisions reached after the discussion without any coercion, and the person must be competent to make a decision. Just to remind you that when we talk about informed consent in the Western view, it's a liberal individual view, so where we have respect for autonomy. And we have to remember that in the traditional African context, it's a communitarian view where one wants to involve the broader family and sometimes even the elders in the community. And this is showing a higher level of respect for autonomy for people from those cultures. So why is there an increased involvement of children in decision-making? I mean, our previous legislation put consent issues at like 14, 16, 18. And I think what's happened is that people believe that we also have to respect children's rights to make decisions about their own bodies. They have to recognize the child patient's developing personhood, and it confers a sense of control and ownership over the treatment decision. Who should make decisions for children? Well, if they're autonomous and competent, they can make their own decisions relating to their healthcare. If they are unable to make decisions for themselves, the parents or guardian make those decisions. I'm sure you've heard of the term assent, which is a bridge between no patient participation, so that's used in very small children, and full patient participation as in competent adults. And it focuses on capacity rather than competence. And it's very much used in the environment of research. We don't do it that formally in the treatment environment, but it is important to keep children informed. And so what it involves is to tell the child what tests and treatments are going to be done, assess the child's understanding of what they've been told, and ask them whether they are willing to accept the proposed care. But it's very important not to ask them unless you're going to take their view seriously. If there's no choice, inform them and tell them that they have to accede to the treatment. So how do we assess the child's capacity for informed consent? Well, first of all, there's reasoning, and that depends on age, IQ, cognitive functioning, and emotional functioning. Understanding, so it's the knowledge of the problem, but also the experience of the problem. So children with chronic illnesses or long-term illnesses or life-limiting illnesses tend to have a much better understanding and can engage with the information at a higher level. It is important that it must be an uncoerced, free choice decision. And then the nature of the decision to be made is essential. The gravity, the immediacy, and the risk-benefit balance. So for example, when it comes to childhood cancer, that obviously is a serious decision to be made, and one often has to negotiate a period, before the final decision is made. So what does our legislation say? So the guiding principles in the Children's Act are the best interests of the child, which I'm not going to spend any time on, and then child participation. And in section 10, it says, every child that is of such an age, maturity, and stage of development as to be able to participate in any matter concerning that child has the right to participate in an appropriate way, and views expressed by the child must be given due consideration. In terms of the age, legal capacity is the age of consent. The Bill of Rights defines a child as being under the age of 18, and the Children's Act says the age of majority is 18 as well. So 18 is the cutoff for child in our legislation, as opposed to the old legislation where the age of majority was 21. Now, in terms of the age of decisional capacity, it has been described in children as young as 7 to 8 years. And as I said before, experience is the most important factor in terms of children's intellectual and moral competence. And I've already alluded to the fact that chronic illness or disabilities have children with these issues have higher levels of knowledge. It's really important to give minors a say in their treatment because it encourages their cooperation and therapeutic goals, but also promotes developing decision-making capacity. There have been pediatric oncology studies where they say that most children older than 9 years are capable of understanding the prognosis of the illness, and the majority older than 11.5 years can make treatment decisions. By the age of 14, the typical child demonstrates the capacity to reason, including the ability to understand the causes and effects of illness, similar to that of an adult. So if we look at the consent in our legislation, so although the Children's Act was promulgated in 2005, the consent issues were only promulgated in 2010. So children over the age of 12 can consent to medical treatment, provided they are of sufficient maturity to do so. They can consent to surgical treatment, provided they are of sufficient maturity to do so, and they must be assisted by a parent or guardian. It doesn't specify how maturity is determined, and it doesn't specify what assisted means. So the kind of things that one looks at for maturity could be measured by biological age, mental age, maturity compared to their peers, the circumstances at home, cognitive ability, level of understanding, participation in decision-making at school, and whether they're easily influenced, etc. Children under the age of 12 needs parental, guardian, or caregiver consent for medical management, and surgical procedures under the age of 12 that requires parent or guardian consent, so not caregiver consent. And it makes no difference what the level of risk is or the invasiveness of the surgical procedure or the medical treatment. When it comes to HIV testing, this is alluded to in section 130. Children of 12 years and older may give consent. Children younger than 12 years may give consent if they are sufficiently mature to understand the benefits, risks, and social implications of the test. If they are not sufficiently mature and it's in their best interest to have the test, consent may be given by a parent or caregiver, the provincial head of social development, or a designated child protection organization. If consent is unreasonably withheld and it's considered to be in the child's best interest to be tested, application may be made to the Children's Court, and court application may also be made if the child, parent, or caregiver are incapable of giving consent. Who is a caregiver? Well, it's basically anybody who cares for a child. So grannies, aunts, other relatives, foster parents, somebody offering temporary safe care, the head of a shelter or child and youth center, and importantly, a child of 16 years and older who's heading a child-headed household. Now, I just want to allude to this very briefly because most of my talk was about the Children's Act, but Marty pointed me to a case recently that happened in terms of termination of pregnancy of a minor. And this is a completely different act from the Children's Act. And I've highlighted the important bits for children. It says no consent other than that of the pregnant woman is required. In the case of a pregnant minor, the doctor or registered midwife shall advise the minor to consult with her parents, guardian, family members, or friends before the pregnancy is terminated. But the termination of the pregnancy shall not be denied because such minor chooses not to consult them. So in other words, a 10-year-old who is pregnant can request a termination and has the right to have it. And this is the case that I refer to. So very recently, there was a minor in Gauteng who was denied a termination despite her trying to get it repeatedly. And the healthcare provider at the primary healthcare facility told her that the position of the fetus meant that she was disqualified for a termination. They did not refer her to a tertiary hospital, and the case was taken up by Section 27. And basically, a part of the judgment is that the minor's right to reproductive health services, bodily autonomy, and access to healthcare services was violated when the primary healthcare facility failed to refer her to a tertiary healthcare facility. So just briefly to get back to the scenarios. So 12-year-old Skylar with asthma, obviously it is really, really important to involve children in decision-making. I think even in wards, we tend to gloss over the children because we think, oh, they can't really consent. We have to involve their parents. And children must be involved in their own healthcare determination. Who should consent to Bongi's surgery? Well, his mother's 17, so she would give consent, but she has to be assisted by her parent or guardian. If it's an emergency and his mother is estranged from her family, so there isn't, say, a grandmother that can give consent, then because it's an emergency and life-saving, the medical superintendent of the hospital where the surgery will be done would provide that consent. In terms of Andisa, undoubtedly, there's no doubt that they must be allowed to consult with the elders and then take the consent process further. And there's a very nice case in that book that Neil McKerrow wrote about a child where they consulted the elders and the traditional healer was involved with consent issues. And then in terms of paternal consent, so yes, the father can give consent if he was involved at the time when the child was born, and if he has stayed involved in the child's care. So in other words, if he's accepted responsibility for the child, he can give consent for the procedure. If there's any doubt about his involvement in his child's life, then obviously one would have to go for ministerial consent. So in summary, health professionals have a moral and legal obligation to involve children in healthcare decision-making. We need to provide the information in a child-friendly way, take the child's views seriously, respect children's evolving capacity and entitlement to consent to healthcare services, respect their privacy and confidentiality, and protect the children from harm. Thank you very much.
Thank you so much for that, Prof Kling. I don't see any questions yet. I really want to encourage people to post any questions, any scenarios that you've had previously that you were wondering about the specific consent for that patient. Please put that in the chat and we can hopefully chat about that later. So I'm now going to ask Prof McKerrow to please start sharing his screen. And yeah, please, let's have a nice and interactive session by talking about your cases as well that you've struggled with. Over to you, Neil. Thank you.
Right. Thanks, Marty. Good evening, everybody. Can you see my screen?
All good.
Okay. Thanks very much. thank you, Sharon, for setting some of the scene for the second half of this webinar. I'm going to present the legal and ethical framework for refusal of treatment by children or on behalf of children by parents or caregivers. And then Mandy Wessels will take over from me, and she will go through a number of case scenarios. So if we just start with the legal provisions, I think if you look at the Constitution, it states that all people, not big people and not small people, but all people have an inherent right to a whole host of conditions, including dignity, life, bodily, and psychological integrity. So the Constitution sets the scene, and to access these rights, people may occasionally require some sort of health service, but for them to receive health care, according to Section 7 of the National Health Act, they need to provide informed consent to access care. It doesn't matter what sort of care they're receiving, they need to provide informed consent before a medical practitioner can provide such care. And the Act further goes on to stipulate what is actually required, what constitutes informed consent. They need to understand their health status. They need to understand the range of investigations and treatment options available to them, the benefits, risks, the costs, the consequences associated with these options, and they need to be informed that they have the right to refuse treatment. So the legal provision is there for people to refuse treatment. However, when it comes to children, we've got to recognize that the legal framework in this country makes additional provisions. The Constitution recognizes that children have the same rights as adults, but in addition to that, they require additional protection because they're perceived to be vulnerable individuals. And Section 28 of the Constitution stipulates a whole lot of provisions for children in terms of their rights. And Professor Kling earlier mentioned the best interests of the child, and this concept becomes particularly important when one's talking about refusal of treatment. So the Constitution states that a child's best interests are of paramount importance in every matter concerning the child. If we then go on to the Children's Act of 2005, it reiterates the fact that the best interest of the child is paramount and lays out some of the factors that people should consider when looking at the best interest of the child standard. Now, the Act doesn't give specific requirements of best interest standard. It merely states that you need to consider the child's age, maturity, stage of development, the gender, their background, and any relevant characteristics that they may have, whether they have a disability, whether they have a chronic illness, their physical and emotional status, etc. So it tells you what one must consider, but it doesn't actually define what a best interest standard is. However, both of those provisions, the Constitution and the Children's Act, require that in making decisions on behalf of a child, one needs to implement the best interest of the child concept. Now, all of those acts talk about what children are entitled to, what adults are entitled to, and Professor Kling has spoken about consent and the requirements of informed consent. So what provision exists for refusal of treatment? Now, if we look at all of the legislation in South Africa, there's no explicit provision for the refusal of treatment for children or by children. However, it's generally accepted that refusal is the converse of consent, and because consent is present, refusal is implied. The Children's Act goes a little bit further, and in a couple of instances, children with disability or chronic diseases have the right not to be subject to a whole host of practices that are detrimental to their health, well-being, or dignity. And in Section 12, boys have the right to refuse circumcision. So there's no explicit right to refuse treatment, but there is implied rights and a few scenarios where refusing treatment is acceptable. The Children's Act then goes on to provide provisions where there has been refusal of treatment, where the state is empowered to actually override the refusal of treatment by parents for their children. You know, and Section 129 of the Children's Act deals with consent, and towards the end of that section, a number of scenarios are presented whereby the minister consents to medical treatment or a surgical operation if the child unreasonably refuses. A high court may give consent where another person that has the authority to consent refuses to do so. And parents may not refuse to assist a child or withhold consent only on the basis of religious or other beliefs. So there is appreciation of the fact that treatment refusal is a reality, and the law makes provision to override these treatment refusals when they are deemed to be not in the best interest of the child. So very briefly, just to summarize, children have the right to autonomy and to participate in all matters concerning themselves. Professor Kling highlighted that fact. The extent of this autonomy and participation is incremental according to the age and maturity of the child, and from the age of 12, as Professor Kling has indicated, children are deemed to be competent to consent to treatment. Children who have a disability or a chronic illness also have the right not to be subject to treatment that is detrimental to their health, well-being, or their dignity. So, as refusal is the converse of consent, as I've mentioned, it is inferred, and if children are considered competent to refuse treatment, to consent to treatment, can they be considered competent to refuse treatment? Many people believe the answer to that is yes. However, there is a counter-argument that states that the competence required for refusal should be set at a higher level than that for consent, because the implications are perceived to be so much worse. But that doesn't exist in the South African context. Now, children and parents occasionally do refuse treatment with no valid reason for doing so, and the Children's Act makes provision for the Minister of Social Development to overrule this decision when the minister believes that the parent or child is being unreasonable. The problem is, like so much of our legislation, definitions do not exist, and there's no clear understanding of what is termed unreasonable. So when we're looking at unreasonable, we now need to start looking at the best interest of the child standard. And in view of their right to autonomy and what constitutes their best interest, any informed decision to refuse treatment should be respected. However, if this decision is ill-informed, then one needs to start considering whether to overrule the refusal. So children or their guardian have the right to refuse treatment, and it's based on a number of scenarios, including the best interest of a child. When the child or his or her parent, guardian, or caregiver refuses treatment, we need to assess this refusal for reasonableness. If it's considered reasonable, then we respect the decision and withhold treatment. If it is considered unreasonable, then appropriate measures should be taken to overrule this decision. So we now need to assess the concept of reasonableness, and really there are three broad areas that people have considered. The first is the best interest of the child standard. The second is the harm principle, which is a concept that's existed for centuries. And then there are newer concepts that are emerging, known as the zone of parental discretion, the sufficiency threshold, or constrained parental authority. So if we look at the best interest standard, there have been a number of definitions for this. The standard against which physicians and courts are expected to make decisions on behalf of the children. It's acting so as to promote maximally the good of the individual, or it's the highest net benefit amongst available options. You'll get the gist of the literature is there is no straightforward step-by-step approach to apply the best interest standard. But the best interest standard does allow for state intervention when parental decisions do not meet this concept. Now, the application of a best interest concept is problematic because best interests are often ambiguous and they're not absolute. They're often interwoven with a whole host of other interests. They're difficult to define. They may be influenced by religious, cultural, or social factors. They are often complex in nature and extend way beyond the health arena and are seldom the sole or primary consideration for management decisions. However, they do need to focus on the child, and we need to select the best option from a number of available options. And in looking at best interests, one does need to identify a threshold for potential harm so that whatever decision is made minimizes the degree of harm that a child may experience. If we then look at the harm principle, this was first proposed in 1859, so it's been around for over 150 years. And John Stuart Mill wrote that the only purpose for which power can be rightfully exercised over anyone of a civilized community against his will is to prevent harm to others. This has been further elaborated on since 1859, and it is believed that the harm principle is effective in preventing harm, should be applied to ensure that no available, less intrusive, equally effective alternative option is ignored, and it is the basis for intervention where decisions are not necessarily contrary to the child's best interest, but does pose harm to the child. Now, unfortunately, there is no definition of a threshold of harm. There are a number of other thresholds that I alluded to. The constrained parental autonomy concept, which has emerged in Australia, allows parents to trade best interests of the child for familial interests as long as the basic needs of each child in the family are secured. And the zone of parental discretion accepts parental decisions provided these do not involve probable harm to the child. And you will see that all of these, the concept that is key is the concept of harm. So one's got to consider what this actually means. And over the years, there have been a number of different definitions, extrapolations of what harm actually entails. And I've listed a number of these for you: the deprivation of basic needs, life-threatening or serious and significant morbidity, loss of life, loss of health, loss of major interests, and deprivation of basic needs, or the loss of primary goods. So you will see harm is far greater than just a physical experience. There's social implications, psychological implications, economic implications from the concept of harm. Now, finally, conditions that we can consider when addressing parental decision-making are listed here for you to look at in deciding whether the best interest of the child is being considered, whether there is likelihood of harm to the child. And if these 8 steps are followed and the decision is made that the best interest of the child is not being addressed, then one is in a position to actually overrule the refusal by the parent. Now, I hope I haven't confused you too much. I've given you a little bit of background, and Mandy Wessels is now going to take over, and she's going to give you a number of case scenarios to illustrate some of the concepts that I've presented to you. Thank you very much indeed.
Thank you so much, Neil. Mandy, yeah, great. Over to you. And then we will touch on all the questions after this. Thank you so much.
Sorry, I was still muted. Thanks very much, Marty. So, and thanks, Neil and Sharon. It's a lovely backdrop to walk into with these cases. I see that on the chat and on the Q&A, we have many cases that have come up as a question. So I'm actually only going to do 4 cases. And the reason for that is that I like to divide my refusal scenarios when I am faced with them at work into basically a diagram that splits them into 2. And I'm really going to give just one scenario for each of these. So essentially in the middle is you've got a parent who refuses treatment for a child or the child themselves. And to guide which arm of the diagram you're going to follow, you need to decide in your own mind, is it reasonable, their request? And to decide on whether it's reasonable is all the principles that Neil has just spoken about. Is it in their best interests? Medical evidence? Is cure possible? Is there an available alternative? Are we still within the zone of parental discretion, which Neil spoke about, and it's a concept I really like and I use quite a bit, or have we reached the harm threshold? And with all of those things in mind that we've just heard, plus all of the legal framework that was discussed by Prof Kling with the ages of consent, we then decide, is this a reasonable request, or is this actually fundamentally unreasonable and we can't just let this refusal lie? And then under each of those, I'd like to divide them further, where the case is possibly a reasonable request. Is it because there's actually an alternative within that zone of parental discretion where we can allow a bit of flexibility in our decision making? And how do we manage that scenario? Or is it reasonable because we've actually reached a point where both the caregiver and ourselves feel that cure is no longer possible, and it's now about deciding where the best care can be provided, and it's not really refusal scenario at all anymore? And then on the arm where we think that there's harm and it's unreasonable, we need to decide, okay, consent is necessary, but there is a bit of time, and we then need to activate our SOP for accessing the ministerial consent or the children's court ruling. Or is this an unreasonable refusal and we need to act urgently? And that is the case where we will approach the medical super. So I'm really going to give a very basic scenarios for each of these and go through the discussion to draw you back to this diagram. So the first case being a 10-week-old baby presenting to your pediatric service with irritability, fever, and a bulging fontanelle. You want to do a full workup to elicit the source, and you suspect meningitis, so you try to get consent for a lumbar puncture. The mum says that she's happy to do IV line, bloods, urine, MC&S, but she's not willing to do to consent to the lumbar puncture. And you then go into some reasoning, and she says that she had a relative who had a lumbar puncture and died shortly afterwards. I'm sure we've all had this conversation before. And so she's actually quite scared of the procedure itself. You also find that she's from quite a traditional background and she doesn't feel comfortable consenting without calling the father of the child and involving the elders at home. So here, this is actually really common. And it may not just be a procedure like a lumbar puncture. You might find parents grappling with issues of IV antibiotics versus first trying something oral, or not wanting to be admitted up front, but rather wanting to try outpatient treatment first. So case one is really a case where there's a little bit of flexibility still. So is it reasonable for them to refuse the lumbar puncture? Well, it depends. Obviously, this becomes difficult when you're really concerned about TB meningitis, and maybe imaging is going to take quite long, and you're really, really trying to tease out if we're going to commit a child to a long term of TB treatment. But what's nice about this case is that you've got a little bit of time. You can start your treatment up front while you go deeper and deeper into this zone of parental discretion and chat and think and get some evidence and talk further to the family. Very often, just out of experience, I find the family come around and agree after you've really deeply addressed their fears, after you've maybe shared some blood results that further point to meningitis, or when you start explaining the alternative, the duration of empiric antibiotics that the child will then be committed to. And sometimes another relative comes along and the whole consent conversation changes. So I find that within the zone of parental discretion, it's very dynamic. The narrative changes quickly. And so the important principles here is that the guiding principle is it may be safe to allow some flexibility within the zone, but to be clear in your own mind and the family's about where the harm threshold lies. And as Neil pointed to, harm is a very difficult thing to define, and it very much depends on the case you're dealing with. So you may, you at the beginning may say, yeah, sure, let's try that. However, if this happens and that happens, we need to revisit consent for this procedure. Or let's try as an outpatient, but if this happens and that happens, we are going to revisit admission. And it's quite important to therefore say, yes, let's be flexible, let's work together, but this is where we're going to draw the line of harm in this case. And I think what I find most important in managing these cases is it gets quite difficult as healthcare workers not to project frustration when the family is not buying into your planned treatment. And sometimes that can actually impair the relationship down the line, and you end up in a space where communication is not open and there's this distrust between us and the patient. So it's quite difficult, but it is important that while we are debating in our zone of parental discretion, that we try really hard not to judge the family harshly for their decision, and we try to therefore keep the communication open. And I think those are the cases where then they may come around. So that's really case one on the arm of sort of possibly reasonable refusal. Case two may be very clear to some people, but I thought it was worth a discussion, and that's just a baby here who's 14 months old with trisomy 21. He had a very big AVSD and was never operated on because the diagnosis was late and there was already established pulmonary hypertension by the time of planned surgery. This little one is well known to your team, comes in regularly for LRTIs and needing oxygen, and comes in to collect the anti-failure medication. But on this particular admission, the child has now been oxygen dependent for 2 weeks. And despite optimizing anti-failure treatment and treating the pneumonia, the baby is still sitting with low sats and needing oxygen. And the mom kind of corners you in the passage and says she's tired. She wants to sign the baby out and refuse any further hospital treatment and take them home. So here it's a little bit different, and it's also quite common, possibly easier to navigate because you know that your cure is no longer possible. So when the medical team and the caregivers have reached an understanding and an acceptance that cure is no longer possible, then it is perfectly reasonable for the family to request that they shift the end of life care to the home. The difficulty lies in cases where the deterioration is really slow, really painful, or when there's oxygen dependency and it's actually physically, practically difficult to move the child home. It's also challenging when we in the family may not have the same timeline. So the family may reach that realization that cure is not possible quite a lot later than we do, despite our best counseling. And then we have quite often a scenario where the family asks to take them home for terminal care and then actually find that they're not coping and that the end of life symptoms are so distressing that they need support, and they come back. And so here it's not really a case of refusal at all, but the reason I've included it is that it's not always so linear. Sometimes these children, we're treating, and then we realize at a point that cure is no longer possible. And at that point, sometimes the family reaches that before us. And at that point, we need to realize that now asking to take the child home is no longer a refusal of hospital treatment, and we no longer need to sit them down and have them sign the baby out. So I don't think it should be seen as a refusal when you're in this situation, but you do still need good signed counseling, a good advanced care plan, detailing that the family's understood that cure is not possible, what the death may look like in the terminal, what the terminal event may be, and that they have the capacity to cope at home before allowing them to go. And then once all of that is done, we can allow it as an actual discharge. I think the family should always know they're welcome back. And I think that's why it's important that, despite the fact that we live in a very litigious society where we want parents to sign everything, we don't want them to feel that they're going against us by taking this child home. We want to think that they're working with us so that they are welcome back. The third case, now moving to the sort of unreasonable arm of the diagram, is similar to a case that Prof Kling already covered, actually, but it is a 2-year-old boy who comes in with a surgical abdomen. The surgeons assess the child and say he needs an urgent laparotomy, suspecting a ruptured appendix and suspecting that there's a lot of pus in the abdomen. The caregiver is 17 and requires, therefore, as mentioned in our first presentation, assistance from her parent to consent. So she consults the grandparents and they refuse, saying that they want the child to go to a traditional healer. They think the cause of this problem is because the ancestors are unhappy that the mum has had her baby so young at the age of 15. So we're now sitting with a situation where the caregiver wants the surgery but is unable to do so alone or consent alone. And the grandparent who needs to give assent is refusing. So in this case, we've discussed that when a teen mum is under 18, she does require assistance from her parent using Form 35, which is available in that handbook, to agree to the surgery. The grandparents here are unreasonably withholding consent for cultural beliefs, and you believe that this is an unreasonable refusal and that this has clearly crossed the harm threshold and is not in the best interest of the child. Here, because of the urgency of the surgery, there is no time to go and approach the minister and get your case into court and write copious reports. So in this particular case, the medical superintendent may and will need to be approached because it's an emergency. So the important thing here is to always remember that in an emergency, which is defined as urgency plus necessity, it can't wait for the court and it's necessary. That's the only cases where medical superintendents may provide the assent or the consent. So in this case, it was assent, but in other cases, the medical super may provide full consent in an urgent plus necessary situation where the caregiver is either unavailable or unwilling to consent. And I highlight this case because I've heard of cases where there was time to approach a court and yet the practitioner went the route of the medical superintendent. And we can't assume as child health practitioners that our medical supers always have this handbook in their pockets. Sometimes we have to go through these books with them when they're having to take big decisions and make sure on their behalf and with them that they are actually acting within the legal framework. So this is just highlighting which cases you would approach your medical super for. But case number 4 is another case where you feel the refusal was unreasonable. So here's a 6-week-old baby, ex-prem, so corrected gestation is only a week, requiring surgery for an inguinal hernia, which is not reducible, but not yet incarcerated. So you've got a little bit of time. But the hemoglobin done pre-op is 5.8, and the family have consented to the surgery, but have stated that they are Jehovah's Witnesses and will not consent to blood transfusion. So here the surgeons and anesthetists don't feel safe to proceed without blood. You know that this hernia needs to be operated on, and you're in a bit of a quandary, but you do have time. So the blood transfusion here is necessary. surgery is necessary, but not immediately so. So the first point of contact always, and mostly because it provides quite a bit of comfort to the family, is I always phone the Jehovah's Witness Hospital Liaison Officer, the number for which is available on their website. They always take the call. They always say that they know legally that if we believe it's necessary, that the law can in fact go ahead and consent. But they ask us first to please try alternatives, where and the alternatives they ask is normally intravenous iron infusions or erythropoietin in the cases of the PREMs. And in this particular case, we don't feel that this will help given the mechanism of the anemia and the time to take effect in the case of the EPO. So I always phone them, and it has helped the family to know that we've had a discussion, and they're very well aware of the Children's Act and of the law, but they always ask, is there any chance that we can do without the transfusion? Then another approach with the Jehovah's Witness family is to discuss with the alternative caregiver. I quite often find that one parent doesn't feel so strongly bound by the religious background, or that a grandparent or somebody else may come in and try and talk with the mother. Bearing in mind that for parental consent, you don't need both parents to say yes, you do only need one. The problem being that we don't like to create disharmony and disunity between a set of parents. So I do often ask for the other parent, but I do try and make sure that there's harmony in the decision before we go ahead. If all the above fails, I wanted to say that quite often I've had mothers who've said they, being Jehovah's Witness and in that community, don't want to sign the consent form themselves, and they don't want to be present during the blood transfusion, but that if the other parent will sign it, they will not obstruct further. And so I've often found that with these particular cases, we don't have to go to the courts. But if all the above else fails, we do need to approach the court, and there it's quite a process, but can actually be done quite quickly, as evidenced by some cases that I know of in Pietermaritzburg. So the guiding principles of this case is that the consent cannot be withheld on religious grounds alone, which is clearly stipulated in the Act. There is time here, so medical superintendent is not the appropriate person in this case because you've got time. And once you realize that the court needs to be approached, it starts with you notifying people senior to you. So if you're a registrar on this chat, you need to notify your HCU, who may escalate to the head of clinical department, the medical manager, the CEO, who then contacts legal services on behalf of the hospital. At every level, there will be medical reports required. So my suggestion is, once you think you're heading towards court, start writing your reports immediately, because when you are suddenly asked to present in court, everything is then ready. And everybody that you've escalated to along the way will need your medical reports backing why you feel that this is an unreasonable refusal and why you want to proceed and overthrow the decision of the family. And then to just remember, when you're in the middle of this administrative mess of trying to run to the court and speak to everybody, the child is still in front of you, and we need to remember to provide ongoing care while we are revisiting consent, contacting Jehovah's Witness associations, contacting the courts, to just remember the child in front of you while you are managing that case. So I'm going to just quickly, sorry, I should have copied it there, but just reflect back, having looked through these 4 cases, just taken you basically through the 4 arms of this diagram in terms of 2 cases where withholding consent may be reasonable and 2 where it's not, and in which one we need to approach medical super versus the court. And on that note, I'd like to hand over to our chair people to manage any questions. I think there are quite a number on the chat.
Thank you, Mandy, for a lovely overview, and I really like your flow sheet and also your examples. So we're going to go to the chats, and we're going to be going through the questions. So first one up is, what about a 13-year-old requiring consent for imaging such as a CT? Should they be allowed to sign for their own consent? I think, Sharon, do you want to answer that one?
Yes, that would constitute medical treatment, and that would be fine.
Great. Now, let's say that 13-year-old was a severe CP. What would the be on that?
No, so the child must have the capacity and must understand the procedure. I think that if one is worried about contrast, then it might be worth asking the parent to provide additional consent, because the child might not understand the implications. But, you know, in the strict letter of the law, a child that's 13 and has the capacity to understand and has the maturity can give consent for that.
Right.
Okay, great. The next question is probably also for you, Sharon. We often struggle with our surgical sisters accepting consent from a parent with a different surname. Is this justified if the patient can provide a birth certificate with the parent's name on it?
Yeah, so that's an interesting question. I mean, obviously, if the parent is the child's biological parent, then the surgical sister should accept that. They have the right to consent to the procedure. I don't think that should be an issue. I don't know, maybe Mandy or somebody has a suggestion of how one addresses that kind of issue.
Yeah, it is difficult. The starting of this unabridged birth certificate does help us in some way, because that does reflect both parents' surnames. It sometimes makes it a little bit easier to pull out that birth certificate and say, okay, but you see the name of the father here on the unabridged birth certificate. But we do know that a number of our patients come in without that when they're opening a file. And if it's, you know, if it's for a major case, it may be worth getting an affidavit. But in the case of a minor surgical procedure, I certainly would go ahead if you believe that that is the caregiver.
Great,
Then
thanks.
our next question is a married minor still required to get parental assistance for consent? Who wants to go for that one?
So, I mean, I would say probably not, because if she's married, she's considered an emancipated minor. So I would say not, but I think it does depend on, you know, what the situation is. But generally speaking, I think it would be fine.
Okay, next question, and I think Mandy answered this for us, but we can maybe just reiterate that. So Mandy, I think you can answer this. A mother gives consent to surgical intervention that would benefit the child, but the father refuses to give consent. Then what should happen?
So it's actually, I mean, I oversimplified it, but if you read that handbook, it's clear that you actually only need one parent to consent. I always, as I said, try to go for harmony. It's really not helpful to create division in a family by what we do. But you do only need one. I think what becomes difficult is the concept of the primary caregiver. We are increasingly having very involved fathers. I'm sure others on the chat will agree. And sometimes the father is really not very involved, but sweeps in just before a procedure and then puts pressure on the mum to refuse. But similarly, we have a lot of fathers who are the primary caregiver, and then the mom comes to stay in hospital because mom is, you know, there's a mother's lodge. There isn't often a father's lodge. And there we really do have to put a lot of weight on the father's decision if we believe that he's deeply involved in the care. I think later on in the chat, there's a question about divorced parents, and that's usually governed by what has been set out in the parental agreement in court in terms of who has the guardianship rights, whether they're equal rights or whether one has full custody of rights. So that's normally outlined by what happened in the divorce settlement rather. But in the case of our common situation of unmarried parents, you actually don't need both. I don't know if you agree, Prof Kling.
Yep, you're quite right.
And then Neil, I'm going to ask you to turn your camera on so it's not just a ladies' game. And I'm going to say, what rights do foster care parents have regarding consent to medical or surgical treatments? And I know we see that quite a lot. I always groan when I hear there's a foster parent involved.
You know, I hate to tell you, I can't answer that. I don't know. You know, they're not the guardian.
No, quite right.
They're a caregiver, so they can consent to medical treatment, but they can't consent to surgical treatment. I mean, Sharon may have a better idea.
Neil's, you're quite right, Neil. Yeah, that's quite right. Yeah.
And I think we often end up going to the social worker and then having to get the superintendents involved, depending on whether it's life and death surgery or not. So I think we all struggle with the same kind of concept. Yeah,
Yeah,
Marty?
so this is just a recap question. So please repeat the age that a minor can give consent for their own child.
Okay, so again, it would be if it's medical, then if they're over 12, they could give consent for their own child. If it's surgical treatment, they'd have to be an adult, so they'd have to be 18.
Then we have quite a number of teenagers who deliver at our facility. Gosh, these are difficult questions. When a teenager or minor is a 15-year-old wishes to give their baby up for adoption, what processes need to be followed? And do the mother's parents need to be informed to proceed, especially on the occasion the parents do not know that the patient was even pregnant and has delivered? Wow, who feels brave enough to do that one?
Neil looks
Man-
brave.
Yeah, Mandy or Neil?
Neil, any idea on the laws governing adoption in terms of age? It's just
No.
Neil's
but
thinking.
I'm trying to think. I'm on holiday, so I've got to get my mind back. I mean, Sharon is retired. I'm on holiday. Both of us are semi-functional. So, you know, I think that, no, I don't know the answer, I'm afraid.
I mean, Mandy, your final comment in your talk was you want to have harmony. And so I think something as major as this, you would have to try and spend some time getting people in and to try and discuss it, because this, for me, would really have life-reaching consequences. And it's probably not an emergency. You've got time to actually get families in and maybe have a more of a discussion than just I think life-threatening surgery is one thing, but giving a child up for adoption I think is quite something else. So I would rather try and wait and get more people involved. I don't know what people do on a practical basis. What do you guys feel about that?
practically what I've noticed. Sorry
No,
to
no,
interrupt.
carry on, Mandy, that's fine.
What I've noticed is that obviously you always have to involve a social worker in a case where someone wants to give up for adoption. And the South African mantra with adoption is you try to get the child in with a relative, almost always. And so what I have actually noticed is our social workers cast the net very wide, looking for aunts, grannies, sisters, to try first to see if you can get a within the family adoption. And they would then know legally whether, if the teenager then says, I don't want the child in any of those situations, I want them to go to a place of safety or something, then they would know. But I think it would be important that we know. So it's a really great question, because we don't want abandonment in a case where we have failed to act. So I'm going to go look it up. I actually don't know.
Thank you. I don't know if anyone wants to add anything.
I
No,
see
I
Abongile's got a raised hand, Marty. I don't know if it's related to this. I don't know if our Zoom webinar allows questions from the audience.
Let's see. I'm going to quickly just go to her and unmute her. Then if she does want to talk, then... So Abongile, you are unmuted. If you have something to say, then please add it in. Okay, great. Otherwise, I'm going to move on to the next question, if that's okay.
Hello.
Yes, do you have? Yes, please answer.
Hi, thank you. Thank you so much. So my name is Abongile. I am a social worker who is working for the Department of Social Development. I am based in Cape Town. Yes, so I wanted to, there's a couple of things that were mentioned, but now I was struggling to talk. But I want to say that, in my opinion, I believe that both parents hold full parental rights and responsibilities, married or unmarried. Okay, so in a cases where, for example, one family is not found or is refusing, if one parent is refusing to give consent with regarding to the child, we really have to assess what the most important thing is, doing what is in the best interest of the child, right? Now, if one parent refuses after maybe explaining the medical condition, what's happening to the child, but this person still refuses, one parent still needs to continue now to sign on behalf of the child because of the medical decision that needs to be made here, right? Now, I know that in most of the times, children are being raised by their grannies, by their aunties, and everything. Now, who makes the decision if there's no biological parent in place? So, in my understanding, according to the Children's Act 38 of 2005, Section 32, it does state that, for example, even though the parents or those caregivers are not holding full parental rights and responsibilities, can make medical decisions on behalf of the child, but not for surgery purposes. Now, this is where we come in. Now, where we can request that a Minister of Social Development sign a consent, right? But now, when does the Minister of Social Development sign a consent? When both biological parents are deceased, or they are nowhere to be found, or they are refusing to sign a consent on behalf of this child. So there's 3 points, where the Minister of Social Development can sign. But there were a couple of other things, but now I've forgotten.
I'm sorry, I'm going to have to
Let me
stop
try.
you there.
Yeah.
Yeah.
Thank you very much for your input. So I think we need to move on to the next question. Matt, I think it's your turn.
Yes, so an 18-year-old who need a blood transfusion accepts that, like, he gives consent, but his parents refused, and the child still lives with his parents. So which decision is better, the child or the parents? He's 18. So I'm going to give that to Prof Kling.
So 18 is an adult, and therefore his view would be respected. I mean, and then obviously one would have to support him. The question is, obviously, I presume that the question implies he's a Jehovah's Witness. If he is, then one would have to support him and, so basically support him. But his views would be paramount in this sort of case.
Thank
If
you.
I can just comment on my experience with Jehovah's Witnesses. So sometimes some families feel that they would prefer us to make those decisions. So it's not them having to make the decision. The church is quite strict on it, but often they feel if we kind of lead them in the decision or make the decision for them, then that feels a bit better for them, rather than them having to make the decision pro or against in terms of the church. So it's often just worth chatting to the family and finding out how strongly they feel about that.
We probably have another 2 minutes to go for questions, and then we need to wrap up. So I've just scanned through it, and the next question. So if the mother of a minor is a known trisomy 21 patient, who should give consent then? Don't know, Prof Kling?
Yeah, so obviously she, depending on what the consent is for, let's say it's surgery, she would not be deemed competent to make that decision, and so her mother or her legal guardian would assist with giving the consent. And if it's a minor that is over 12, that person can give her own consent, his or her, but for surgical treatment, a legal guardian would have to assist.
Okay, and then a 14-year-old patient is dying from cancer. The parents refuse for the team to speak to the child about end of life, even though the child is very aware and has given up on life. Can the team still speak to the child? And I think this holds for any chronic illness where somebody's actually towards the end of life. I don't know who wants to answer this one. Neil, are you keen on that one?
Yeah. With all these consent issues, what we're telling you is what the law says. But I mean, there are comments in the literature that the law is an ass. And the law is often an ass. And if we start looking at reality, the law says a 14-year-old can consent or do whatever. But even a mom in many of our families is not empowered to give the consent. She needs to consult elders. And at the end of the day, the single most important thing is communication. Communication with the patient, communication with the guardians, the parents, the caregivers. You need to have people on board. They need to understand what the problem is, what the options are for management, and explore their responses. And it's exactly the same thing here. One needs to sit down with the parents and understand why they don't want their 14-year-old to understand. It's not a simple yes and no. It's about communication and ensuring that people understand what the issues are and that their decisions are based on information and understanding of that information. Thanks.
Right.
Okay,
Mandy?
thanks. And then just one, probably the second last question. Why is 12 the age of competence? I also want to know.
So it's not competence, it's consent. And I think the legislators looked at the literature. There are lots of studies that show that at the age of 12, children can engage with certain aspects of their own healthcare. And I think that I don't know why the legislators decided. In other countries, it's 16, and some countries are even older than that. So I don't know why our legislators decided on 12. I mean, it's quite interesting with the COVID vaccination. They said children over 12 could consent to their own COVID vaccines, and a lot of parents were very unhappy with it. And yet that was according to the law. So, I mean, I think that I don't understand why they did it, but I think a lot of children of that age can be involved in decision-making, especially if they've got long-term health conditions.
I think that we were going to do that as the last question. So do parents or caregivers have the right to refuse vaccines? So I think, Sharon, you kind of brought that final one up. I don't know if you want any final comments on that, because I think that's going to be our last question for today.
Yes, I think that would fit in very nicely with both Neil and Mandy were talking about the zone of parental discretion. I mean, they can refuse vaccinations. Obviously, we would try and encourage them that it's important to have their children vaccinated, but it's one of those scenarios where the harm does not outweigh the child's best interest, and so one would have to respect that.
Yeah.
Okay,
Great.
that's,
So I
yeah.
think thanks so much to everybody for your questions.
Can I just add to that? You know, if you look at what is happening in many European countries, they are going to a punitive approach towards enforcing vaccinations, where if your child is not vaccinated, you lose social benefits. And in Italy, you can even be imprisoned. So South Africa has not opted for that approach very deliberately, because access to healthcare is very difficult for many of our families. I mean, in KwaZulu-Natal, Limpopo, the Eastern Cape, a quarter of children live more than half an hour from their nearest health facility. So our approach is one of education. You have to educate the parents, understand why they are refusing vaccination, and work on their understanding. And, you know, that's the key to all of this. It's communication, information, and understanding. Thanks.
I think you summarized it nicely, huh?
Yeah, I really think we must just finish with Alan's questions, because that is also important for us. So what happens if the parents refuse treatment? So specific kind of vaccines or vitamin K, and there is harm for this child. The child does become sick and they didn't take up this prophylaxis. Is there any legal repercussions for that parent? Or so that is a good question to me, because I also want to know this. Mandy, I don't know if you want to take that difficult one.
Thanks, Marty. No, I mean, I think a lot of what we do when you talk about refusal and consent is protect ourselves. So the parent can't come back and say, you allow this child to bleed because you didn't give vitamin K. And we say, but you refused. But we don't often talk about the other way around. However, we do know that we can take legal action against families where we think there's been deliberate harm or neglect, reporting it via our Form 22. But in that zone of parental discretion, I don't think any of us would be brave enough to go and take them to court and say, you refused this vaccine and now look what happened. It's a really good question. I don't know, Neil, Sharon have many more years of experience behind them. Yeah.
Anything else from Neil or Sharon?
I don't think anybody's going to litigate against a parent that caused harm to their child. Not in this country anyway. There are cases elsewhere where they did that. But I mean, I think as healthcare professionals, I think Neil put it very well. We try and inform people. We try and explain to them why it's important. And in the end, unless they exceed or transgress that threshold of harm, all we can do is advocate for the child and try and support people. And I don't think, I mean, so yes, somebody might then lay a criminal charge against the parents, but it wouldn't be the healthcare professional that does that.
And I think that's a lovely way to end. I think what I've learned in my years of practice is try and get everybody involved. What we've sometimes done is get entire families in. It takes time, so get grannies, grandparents, often get the elder folks involved. And interestingly, last week I was summoned to a Zoom discussion with a large family. Interesting concept, but it actually worked really well because we could explain where we were coming from. The family could explain where they're coming from. And I think maybe modern technology has really improved access, especially if folks come from different parts of the country. So I think communication is what we're saying. There are a zillion more questions. Sharon, thank you for answering those in the chat group. And for me, I think there's obviously definitely room for another webinar on this topic in the foreseeable future. So thank you very much to Neil, to Sharon, to Mandy for coming on to this. Thank you for Abongile from a social work point of view. And of course, always thank you to Marty for putting these excellent webinars together. Really, really have enjoyed it this evening. I've learned a lot. Don't forget about the Congress. I'm going to mention it again, the 8th to the 10th of September. If you've enjoyed these webinars, please come along to that meeting. We're really hoping to do lots of in-person discussions and chats, maybe over a glass of wine. We're not allowed to do that at work anymore, but definitely come along to that. And we look forward to sharing more interesting discussions with you. So over to Marty. Thank you very much, and we'll see you in a month's time.